Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. EM Cases is part of SREMI, Schwartz-Reisman Emergency Medicine Institute, the nonprofit organization dedicated to improving EM care through research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. So here's some facts to consider. 30% of ED patients have at least one drug-related problem contributing to their ED visit, which includes adverse drug reactions and subtherapeutic dosing. More than 1 in 9 ED visits are due to drug-related adverse events. And many of these drug-related adverse events are due to drug interactions, which are almost entirely preventable. I don't know about you, but besides the obvious ones, I haven't paid a whole lot of attention to drug interactions over my 20-plus year EM career and didn't realize how much they actually contributed to morbidity in our patients. Presentations like syncope and near syncope, delirium, falls, and altered LOA are often triggered or directly caused by drug interactions, and these drug interactions are often overlooked. We need to recognize drug interactions as a cause of these presentations, and we need to avoid prescribing drugs that interact with other drugs that cause badness. In this 1 or 2-part podcast series, we'll see how deep we go into all of these things, we'll delve into some common presentations that require having drug interactions in the differential diagnosis, which combinations of drugs to avoid when ordering in the ED and when prescribing for outpatient therapy from the ED. And to help us sort through the mountain of drug interactions, we have none other than my friend and colleague, who we all know and love, Dr. Walter Himmel. Welcome back, Dr. Himmel.
Thanks so much, and I'm really thrilled to be here. I love this topic.
And I'm honored to have back on the show a physician who probably has a better understanding of this topic than any other. He trained as a pharmacist before doing his internal medicine residency and toxicology fellowship. He's the head of toxicology at the University of Toronto. He's a master educator and public speaker. We were lucky to have him speak at the EM Cases Summit in 2023. Welcome back, Dr. David Juurlink.
Thanks, Anton. Good to be here and looking forward to it.
All right. So how are we going to tackle this enormous topic of drug interactions? So I've got a plan. This is it. I'd like to first discuss high-risk patients and why they're high risk, like older patients, renal patients, cardiac patients, mental health patients, and then go over the top 3, 4, or 5 categories of drugs where drug interactions most often occur. The big 3 are antimicrobials, analgesics, and cardiovascular drugs. And so to kick things off, let's talk about an interesting case. So here's the case. A 28-year-old man with a history of depression and opioid use disorder presents to the ED with shortness of breath and near syncope. Medications include citalopram, trade name Celexa, and loperamide, trade name Imodium, which he admits to abusing the Imodium. Initial ECG shows sinus rhythm with right axis deviation, an undetectable PR interval, a QRS of 168 milliseconds, and a QTC of 693 milliseconds. He's given IV sodium bicarb and magnesium sulfate, and he's admitted to the ICU, and eventually he develops torsade de pointe, or in the United States, I think it's sometimes called torsade de pointe. Lidocaine and isopril infusions are started, and an external pacemaker is placed. He's discharged in stable condition after a 2-week stay in hospital. So, Dr. Juurlink, from a drug interaction and tox perspective, what's going on in this case?
So I think there are a couple of things going on here. The first and most obvious is loperamide toxicity. This is not something we see very often, but loperamide is a drug most of us have prescribed or even taken as an antidiarrheal. And it works as an antidiarrheal because it's an opioid. It binds to opioid receptors in the gut and it slows peristalsis. And that's how it works. Standard doses of 8 or 16 milligrams a day just aren't absorbed to any appreciable extent. But we do see people who sometimes take hundreds of milligrams a day expressly for the opioid side effects, either to get high or to stave off opioid withdrawal. So I think that's likely going on here. And so I would hazard a guess that this fellow is taking much more loperamide than, the average person with traveler's diarrhea. So he likely has opioid use disorder. And that's something to come back to after the case resolves because we have treatments for that. But from a drug interaction perspective, I think what we're seeing here is a combination of the effects on the QT interval in particular of the antidepressant and the high-dose loperamide. And not to get too pointy-headed, but when we have drugs that do the same thing or do opposing things to a tissue, we sometimes talk about that as a pharmacodynamic drug interaction. The terms pharmacokinetic and pharmacodynamic sometimes put people to sleep, but it's really useful in the context of drug interactions because all drug interactions fall into one of those two categories. If you think of pharmacokinetics as what the body does to a drug, after you take a tablet, you swallow it, it's absorbed, it distributes, it's metabolized, it's eliminated. Anything that tinkers with those processes for a given drug will precipitate a pharmacokinetic drug interaction and change the level of the drug. So this is not that. This is a pharmacodynamic interaction where two drugs have, in this instance, additive or even synergistic effects on a biologic process. So here we have two drugs that together cause QT prolongation, and it's 1 + 1 is 5 or even 10.
So pharmacodynamics, I think, is what the drugs do to you. And pharmacokinetics are what you do to the drugs. Well, I've got one other warning to the audience. Drug interactions are a bit like speeding by 10 miles an hour. Or, as I used to say, they're a bit like unprotected intercourse. You usually get away with them, and you usually get away with it. But when things go bad, they really go bad. So there's one principle you take home: always consider the drugs. And if 99 times out of 100 drugs are not a problem, don't worry. The 100th time, it will be a problem. Keep it in the back of your head.
Good analogy.
One big thing for emerge docs is to be aware of loperamide toxicity as something that can present in a weird way. I mean, the usual story is a young person who presents just like this one did with syncope, and they have the most bizarre ECGs. Like they're in their most severe incarnations, even when the patient is awake and talking to you. The QRS is crazy wide. It almost looks like hyperkalemia. And that is a reflection of the fact that loperamide doesn't just cause QT prolongation at high doses, it causes sodium channel blockade. So it's almost like a tricyclic in a patient who isn't exhibiting the typical CNS features of tricyclic toxicity. So if you have a young person with an episode of syncope and a grossly abnormal ECG, I would just put loperamide toxicity on the differential and ask about it because it's not something that people are typically keen to volunteer.
Absolutely. And this certainly wasn't on my radar until we started preparing for this podcast.
And I would even make a more basic point because I agree with everything we've just heard. I would say if you have a situation and you're wondering what in the world is going on, always keep in the back of your mind drugs, drugs, drugs.
All right. So that case was just to give you a little flavor of the possibilities when it comes to drug interactions. Dr. Himmel, besides near syncope or syncope, like in this case that we just discussed, can you just go over for us some of the common ED presentations that we need to think about drug interactions as a trigger or a cause? I mean, in some ways, we need to think about drug interactions in every patient we see, but which are the sort of the high yield ones? Which are the ones that we really should be looking very carefully at drug interactions?
Well, I certainly agree. In the back of your mind, you always got to see drugs, especially when nothing makes sense. But yeah, there are a couple of classic situations. The first one is this. Fragile people. Who are fragile people? Fragile people are people who have decreased physiological reserve, which is basically the elderly, or people with multiple comorbidities. So when you have people with decreased physiological reserve, the elderly, and people with multiple comorbidities, the chance of having a drug interaction is much greater. Secondly, people on drugs. If you're taking 3, 4, 5, 6 drugs, you're more likely to have a drug interaction. And the third thing is, when a person who's healthy and fit has a disease you can't explain, think about drugs. So are the common presentations. Syncope is certainly a big deal, but almost anything. For example, the brain, any altered state. You're going to think about a stroke. You're going to think about trauma. Think about drugs. Cardiac conditions, heart failure, shortness of breath. Syncope is a big deal. You're going to think about drugs, and there'll be a hint. The patient's going to be on 2 or 3 or 4 or 5 drugs. Metabolic conditions, hypokalemia, hypoglycemia. Think about drugs. It'll be obvious because these patients are going to be on 2 or 3 or 4 or 5 drugs. Now let me give you an example I can't resist. A patient came into the hospital by ambulance. They were unconscious. The story was this. Their significant other left in the morning. The person was asleep. The person had come home several hours earlier from a party. And when the significant other returned 5 o'clock that day, some 8, 9 hours later, the person was asleep. Well, obviously, they weren't asleep. They were unconscious with a GCS of 4, and the person came to the hospital. Now, of course, I suspected head injury, a brain bleed. I asked about drugs, and of course, I got the answer they don't take any drugs except alcohol from a party last night. The person became sweaty. They became hypertensive, tachycardic, had to be intubated. One of my colleagues came along, and as we're intubating the person became profoundly diaphoretic, profoundly spastic. And my colleague checked the legs, and there was clonus. All along, and I'm preparing for this talk, by the way, I'm thinking, head injury, decorticate, decerebrate. I asked the significant other, is the person taking any drugs like cocaine or meth? No, just alcohol. Well, of course, you know what turned up. Serotonin syndrome. The person had clonus, hypertonicity of the legs, and guess what the urine showed? Meth and cocaine. As it turns out, they were taking SSRIs. What are the presentations? Almost anything that you can't explain. But here's the problem. Your diagnosis is going to be delirium, trauma, syncope. If they're on 2 or 3 drugs, consider the drugs, or you're going to forget about it and miss it again and again and again.
So, Dr. Himmel, you had mentioned that fragile patients, older patients, patients with comorbidities on multiple medications are at high risk. I want to talk a little bit more about the 3 general groups of patients who are at high risk. So one are the older patients, the other is the renal patients, then the patients with mental illness. And I want to expand a little bit on older patients. As you were mentioning, drug interactions in older patients contribute to falls, to CHF, to delirium, and also to renal failure. We're all aware of the problems of polypharmacy and that older patients have, sensitive protoplasm. And this is not a small problem. 15% of older patients have adverse drug reactions, and 50% of those are preventable. So could you give us a sense of why older patients are at risk? And then a little bit about what common drugs on their list we should be paying particular attention to?
Yeah, so I'll take those one at a time. So I think the first and most sort of obvious reason why older people might be at greater risk is they tend to take more drugs than younger people, right? So the probability of a drug interaction being at play is directly proportional to the number of drugs a person's on. Another reason is that they often have comorbidities that make drug interactions more likely, and I think the main comorbidity here is going to be renal dysfunction, or more likely to manifest. So cognitive impairment is something we see often in older people, and it's not uncommon to see drugs that can affect cognition used together. Sometimes it's a little tough, even at the bedside, even when you're thinking about this phenomenon, to know how much of someone's cognitive issues relate to their baseline status or to meds individually or meds in combination. 2 other thoughts. One is that because older people are often frailer than younger people, they're often less able to tolerate the effects of a drug interaction. So a drug interaction that might be an annoyance to me or you might actually be enough to bring an older person to hospital. And finally, sometimes the effects of drug interactions can be mistaken for age-related problems. So delirium, constipation, falls, as you said at the outset. And we see these so often, we sometimes don't think, as Walter pointed out, we sometimes don't think to invoke drugs as part of the explanation. Your second question was about what drugs to worry about. And I think, again, the easy answer would be just think about all drugs, and the more drugs they're on, the more you should think about it. But that's not really practical advice. I think it's important, from an emerge doc's perspective, I think it's important to focus on 2 groups of drugs. One is groups of drugs where it's important that the drugs stay in the therapeutic range, right? So that includes drugs with important toxicities. So anticoagulants, warfarin, apixaban, rivaroxaban, for example. Drugs that can cause hypoglycemia, so primarily secretagogues like sulfonylureas or even insulin, and sedating drugs in combination. And the other class of drugs is drugs where you might not want the level to fall too low. So immunosuppressants or anticonvulsant drugs, these are especially prone to drug interactions, and you can get into trouble when the level's too high or when it's too low. Finally, drugs that emerge docs might start more often. So antibiotics, NSAIDs, and opioids. It's generally the introduction of a new drug into the mix that stirs the pot and causes trouble for patients. And so it's very common for people to leave the emergency department with a new medication. And when that new med is an opioid or an NSAID or an antibiotic, I think you want to be especially vigilant about potentially triggering a drug interaction, especially when people are on high-risk drugs to begin with.
All right, fantastic. So antibiotics, NSAIDs, opioids, those are some of the ones that we use very often, and patients leave the department with us prescribing them. So we got to think about drug interactions when we do prescribe those. And then we have to think about the therapeutic range of the medications that the patients are already on, particularly anticoagulants and sedating drugs in combination.
Yeah, so I use a couple of hints to keep me remembering things. I use the rule of the antis. Not my anti-LC or my anti-ANA, but there's antiemetics, antidepressants, antipsychotics, anticoagulants, antihypertensives. I gave you sure really, really, really big ones. Antibiotics, the macrolides and the fluoroquinolones, they're a big deal. The antiemetics, Gravol and Sofran, fatigue and QT intervals. The antidepressants, they have a big issue about serotonin syndromes and drug interactions, but usually in large doses or when you're combining multiple antidepressants. So always think about the antis. They're a big deal.
So that's a bit about older patients and why they're at risk for drug interaction problems and what common drugs to look out for. The next of the three high-risk groups we should be vigilant about are patients with mental health issues. What are some of the common drug interactions we should be on the lookout for in our psych patients? You already had mentioned, antipsychotics, antidepressants, but are there any ones in particular and then any additions to those that we should be looking out for in particular?
Well, I think there's a couple of approaches to this. The first thing is, I think tons of people have issues with depression and anxiety, including myself at times. So if you're that kind of person on a single antidepressant and take it a small dose is not a problem. But within that group of patients who have emotional pain and suffering, there are some people who are on 2 or 3 or 4 drugs, 2 or 3 antidepressants, plus an antipsychotic, plus a sedative. That's where you're going to have problems. If you're on psychiatric medications, if you're on multiple medications in large doses, that's when you have problems. And what are the problems? Well, they're pharmacodynamic. What drugs do to you? Antidepressants have major roles on the cytochrome system, the P-glycoprotein, and you've got to look it up because it's not obvious. Antidepressants do interact, and I'll give you an example. I saw a patient about a year ago who was on 2 antidepressants, and the person had the following complaints. They were restless, agitated, pacing, uncomfortable, feeling chilly at times. I noticed the following about the person. Heart rate was about 120. The person was sweaty, and they were restless. And of course, I also noticed that they were taking 2 SSRIs in a large dose and an antipsychotic in a large dose. Of course, in this case, what are you going to think? There's a drug problem going on. So there's a hint. It's not just the fact they have psychiatric stress, but they're in large, large doses and multiple medications. But here's the problem. I did speak to the psychiatrist. I said, well, this person is sweaty and tachycardic. I think they may have a very minor version of serotonin syndrome. Now, of course, I was completely dismissed and ignored. And the drugs were reduced, and I found later his symptoms to settle down. These subtle forms of presentations are often easy to overlook. So certainly multiple antidepressants, high doses, combined with enhancing drugs like antipsychotics produce potential risks. That's pharmacodynamic. Then there's pharmacokinetic. Antidepressants have a major impact on the cytochrome systems, the P-glycoprotein systems. You've got to look it up.
So those are a combination of the antidepressants and antipsychotics. That seems pretty obvious to me if people are on massive doses of a combination of these drugs. What are some of the other drug combinations with the antipsychotics and antidepressants that we really need to be on the lookout for? Dr. Juurlink?
Well, here again, there are lots of potential answers to that question. The ones that come to mind first, most, not all, but most of the drugs that we give to patients with mental illness many of them at least, have sedating effects. And so got to keep in mind the possibility that when you're adding multiple sedating drugs together, 1 + 1 + 1 is not 3, it's 10 or even 20. I think sometimes NMS, neuroleptic malignant syndrome, I think is sometimes the result of a drug interaction with people. We know that the more antipsychotics a person is on, and the higher the doses, the higher the risk of this condition. I make it a matter of routine to put NMS on the differential for any patient who is on an antipsychotic and who is sick, or any patient who's got more than one antipsychotic on board at the same time. It's such a difficult diagnosis to make unless they present with a full house, and they usually don't.
So just as a reminder, the diagnostic criteria for neuroleptic malignant syndrome are 2 of the following: fever, muscle rigidity, tachycardia, altered mental status, high BP, and excessive sweating. Now, that sounds an awful lot like serotonin syndrome, but the key distinguishing feature between NMS compared to serotonin syndrome is that patients with NMS have that lead pipe muscle rigidity, while patients with serotonin syndrome have clonus and hyperreflexia.
And I guess the other potential harm that can befall psych patients is that many of the drugs that we use can cause QT prolongation. And this really depends not just on the number of drugs, but the actual drugs they're on within classes. So it's not widely appreciated, for example, that there are some important within-class differences in the risk of drug interactions. And with regard to antipsychotics, for example, I mean, there are some that I think we're scared of. Haloperidol is the one that comes to mind, but I mean, as a QT prolonging agent, but it's nowhere near as severe as some of the newer agents that are out there, and in fact, some of the older ones. Antidepressants, Walter's talked about them at some length, and he's made some really good points. One of the little pearls I like to teach people is, there are lots of antidepressants that don't have any effects on cardiac conduction, but citalopram, escitalopram, and to a lesser extent venlafaxine are drugs that can cause QT prolongation. And so using, for example, citalopram in combination with an antipsychotic that causes QT prolongation is just asking for trouble, or using it with methadone. Any drug that has the potential to cause QT prolongation, you add them together and you're asking for trouble.
So those are some of the key antidepressants and antipsychotics that we need to think about when it comes to prolonged QT. For our patients with mental illness, most of them will be on 1 or 2 or 3 or a combination of antidepressants and antipsychotics. And the other drugs that we really need to think about that can trigger prolonged QT are all the antis, so antiemetics, antidepressants, antibiotics, and also lithium. And then in terms of serotonin syndrome, we need to think about fentanyl, cocaine, Flexeril, Demerol, methadone, Maxarin, Tramadol. There's a whole long list of medications that have serotonergic properties. And so for our psych patients, really, I think if we concentrate on the QT and the serotonergic drugs, that's where we'll get our biggest bang for the buck in terms of discovering an important drug interaction.
The QT stuff and the serotonin stuff is the most dramatic when you see it. If the QT is 700 or the person is seizing, and obviously it's serotonin syndrome. But I think Walter's made some really good points about drugs that can cause QT prolongation and drugs that can, especially in combination, cause serotonin syndrome. And those are really important interactions. I think just probabilistically, the thing we're more likely to see or cause is just an increasing burden of CNS depression when we combine antipsychotics, some antidepressants, sometimes alcohol is in the mix, sometimes opioids are in the mix. And these can collectively exert a much greater toll on someone's cognitive function when they're combined together. And it's often hard to know exactly how much of the way someone is because of the drugs or because of their underlying mental health problem.
Yeah, just beware of cognitive bias. It's so easy to blame a patient's symptoms on the patient and their illness. I would just say when they have significant psychological issues and they're on multiple drugs, and because they haven't responded over the years, there are more drugs and more drugs and more drugs from 2 or 3 families. Think about altered states being due to drugs. If they're sweating tachycardic, think about the possibility of serotonin syndrome. And if they're in 3 or 4 different families of drugs, or 2 or 3 from the same family, in the back of your mind say, gee, maybe I should get an EKG once they're coming into the hospital and I'm going to give them more drugs. Just keep in the back of your mind. In any given year, you'll see hundreds of patients And how many are really going to get all that ill? Not that many. But that's where you make a difference. That's where you save a life. 99% of what we know, we use 1% of the time. Used to be called the 80-20 rule. I call it the 99-1 rule. And remember, the one time you say it, no one's going to believe you.
Excellent. So just to review there, for our patients with mental illness, probably the most common things are a combination of sedating drugs, and that their presentation to the emergency department actually might have more to do with the combination of drugs that they're on that's sedating them as opposed to their primary mental illness issue. And then there's, the generally more emergent things like the prolonged QT, as well as serotonin syndrome. And so just to be aware of some of those medications that we might not think about that can cause serotonin syndrome and prolonged QT, as well as sedation. So we've talked about the fragile older patient. We've talked about patients with mental health issues. The third category of patients I want to talk about are renal patients. And of course, there might be some overlap here. There are many older patients who also have renal problems. But Dr. Juurlink, could you just tell us first what we need to understand about renal patients that make them at high risk for drug interactions?
I think the reasons why drug interactions are particularly important in patients with kidney disease are mostly intuitive. One is that they may have difficulty clearing drugs that rely, or they will have difficulty clearing drugs that rely on the kidney for elimination, but also they typically have renal disease for a reason, right? Maybe they've got diabetes or they've got hypertensive nephrosclerosis, and they're on other drugs to treat the conditions that are themselves responsible for the renal disease. And so they're kind of inherently a bit of a setup from the get-go.
Great. Okay. So yeah, there's sort of the obvious thing we think about, which is renal clearance, but also, like you astutely pointed out, they're typically on many medications that do tend to have risk for drug interactions like ACE inhibitors, et cetera. So that's a little bit about why renal patients are at risk for drug interactions. I want to talk about sort of the common drug interactions that happen in renal patients. Could you give us a few examples of what we should be looking out for in renal patients when it comes to drug interactions?
Yeah, so in renal patients, there are three scenarios that come to mind. And the first for most of us is going to be the potential for hyperkalemia. Right? Obviously, the kidney is critical to getting rid of potassium, and the lower your GFR, the harder that is to do. But we have lots of drugs that predispose to hyperkalemia. ACE inhibitors and ARBs and spironolactone are kind of the biggies, but less widely appreciated. Trimethoprim, NSAIDs, heparins. The risk of developing hyperkalemia and potentially life-ending hyperkalemia from these drugs goes up dramatically when they are used in combination, and when they are used in combination with someone who is inherently less able to eliminate potassium. So that's probably the first thing that comes to mind.
So yeah, we did a EM quick hit on trimethoprim and ACE inhibitor combination can cause hyperkalemia. The other two you were saying were NSAIDs and heparin. Mm-hmm. And I suspect that many of our listeners aren't fully aware of that. So just to clarify there, so if you have a renal patient who's, let's say, on an ACE and you add NSAIDs, that would put them at increased risk for hyper-K?
Yeah, I think it's more likely that they'll get into trouble with salt and water retention, but hyperkalemia can often be an accompaniment of NSAIDs as well. So we see this from time to time. The heparin thing is, I think, a little less widely appreciated, but heparin can actually suppress aldosterone production. And it's just another mechanism by which hyperkalemia can arise with the use of drugs that we normally don't think of as having this as a side effect.
And is that all the heparins? Is that the enoxaparins?
I believe it is. Good question. Actually, I'm not entirely sure. I think it's more typically seen with the unfractionated ones, but I think it's also a potential risk with the low molecular weights.
Okay, interesting. I learned something new there. So while I was aware that trimethoprim and ACE inhibitors can cause hyperkalemia and you should avoid starting someone on trimethoprim for their UTI when they have renal disease and are on an ACE inhibitor, the heparin and the NSAIDs are something to also think about in your renal patients. So in our renal patients, there's hyper-K, so ACEs, ARBs, spironolactone, trimethoprim, heparins, and NSAIDs. And you said there were three categories.
Yeah, the second bin of problems that these patients get into is that, as I said at the outset, there are many drugs that are really heavily reliant on the kidney for elimination. And when you add another drug that, say, increases the levels of those, I use DOACs, and colchicine is a biggie. We don't see it very often, but digoxin, the magnitude of the drug interaction is just inherently greater in patients who have underlying CKD and can't clear the drug. So, all the more reason to be cautious. And someone who's on a DOAC or is on DIG, is on colchicine and has an element of renal insufficiency, we're careful with those drugs in those patients anyway, typically adjusting the dose or the interval depending on the drug. But adding other drugs into the mix with those classes of drugs in particular, and there's hundreds of drugs that could cause trouble here, should be done very carefully.
So, yeah, of course, we use DOACs all the time, and we're prescribing people DOACs to go home for atrial fibrillation, new onset atrial fibrillation we see often in the emergency department. So, again, those renal patients, and we have to be careful with DOACs, and there needs to be a dose adjustment, and especially if they're on other medications that can affect the kidneys adversely. And then colchicine, we're using, pericarditis. We might be starting someone on colchicine. And then occasionally we will use digoxin in that patient with AFib and CHF, for example. And of course, there's still some patients who take digoxin regularly. So the DOACs, digoxin, and colchicine are definitely some ones to look out for in those renal patients. So just to keep track here, in our renal patients, we've talked a bit about hyperkalemia and the trimethoprim, heparin, and NSAIDs that are less appreciated for hyperkalemia. Then the elimination drugs, DOACs, digoxin, and colchicine. And there was a third category of patients?
Yeah, the third bin is, especially in patients with advanced renal disease, they'll often be on a phosphate binder like calcium carbonate. It's not widely appreciated that calcium, along with iron and magnesium, can complex with other drugs in the lumen of the GI tract and inhibit their absorption. So the best examples here are the quinolones. All of the quinolones are subject to this, tetracyclines, and thyroxine. And of course, this is not exclusive to patients with renal disease. Someone who's taking high doses of calcium carbonate for osteoporosis would be at risk of this too. And so the concern arises when, let's say you put somebody on a course of oral Cipro and they take it together with their calcium carbonate. Well, their absorption of the Cipro is going to drop by at least 50, if not more, %. This interaction is easily surmounted by just separating things out in time. Right? Give the Cipro at 8 in the morning, give your calcium at 10, problem solved.
Wow. I had no idea about that. That's interesting. I never knew about the phosphate binders, so mainly calcium. And there are a lot of, again, our older patients and I suppose renal patients who are taking calcium.
So this is why if you go to the pharmacist with a prescription for a tetracycline or a macrolide, they will put a little sticker on it that says, do not take with dairy products. This is the exact same rationale. All they're trying to do is not have the absorption of the new medication impaired by a cation that grabs onto it in the gut and complexes with it and makes it insoluble.
Interesting. Okay. So quinolones and calcium don't go well together.
Correct.
Yeah. So if you're taking iron or calcium, take them by themselves, obviously. Now, I want to make another point about kidney disease. There's two kinds of kidney disease, right? There's the obvious kidney disease, not so obvious. If you're well on the way to getting dialysis and your GFR is 10 or 5, I think we're all going to realize there's issues. And of course, all drugs, almost all drugs, I should say, need some sort of renal function to be cleared. Even drugs which are metabolized by the liver eventually have to be secreted in the urine. But I'll tell you what you're going to see on a regular, daily basis all the time. There are some patients who have mild renal insufficiency, perhaps a creatinine in millimoles of 130, 140. It's not that bad. These patients are very sensitive to NSAIDs. In fact, lately, I think there's been an epidemic of hypertension. In the last couple of years, I've seen more hypertension than ever. I've noticed many people go on NSAIDs if their baseline creatinine is slightly elevated, 130, 140, 150. And if they're on an antihypertensive medication already, if you give them an NSAID, they're going to get hypertensive. So people with mild renal insufficiency have a problem. And furthermore, in terms of pharmacodynamics, if you've got mild renal insufficiency and you're on antihypertensives, and now you get the stomach flu, or you haven't eaten for a couple of days, you get a bit dehydrated, you can get acute kidney injury like anything. So AKI in somebody with unrecognized or minimally impaired kidneys can very easily happen because of pharmacodynamic interactions with NSAIDs and with stress such as gastroenteritis.
Now, a word from our sponsor, Metricade, the experts on scheduling systems. Metricade system is partially tech and partially a professional service. The web-based tool allows me to let Metricade know exactly how I want to be scheduled. The technology and the expert schedulers work together to produce a schedule that somehow meets the needs of the department, filling every shift while still letting me work more of the shifts I want and fewer of the shifts I don't. When you have a problem, there's an expert scheduler answering the phone who probably fills 2,000 to 4,000 ED shifts a month. They know all the intricacies of ED scheduling. This is not an automated push-button schedule. The technology is a tool to help an expert build a schedule to suit your needs exactly. Go see for yourself at metricade.com/emcases. So we've covered the various kinds of patients who are at high risk for drug interactions, and we've talked about some of the specific drug interactions. I want to reframe the discussion and talk about different categories of drugs. We've already talked about psych drugs. I want to talk about antimicrobials, analgesics, cardiovascular drugs, and blood thinners. And just to whet our appetites, let's start off with a case. A 47-year-old woman with a history of depression on sertraline 50 milligrams daily and citrazine 10 milligrams as needed for seasonal allergies comes into the ED after a trip and fall on stairs with an obvious distal radius fracture. It was decided to do procedural sedation for reduction of the fracture. She was given 50 micrograms of fentanyl, followed by 1 milligram per kilogram of propofol. A minute or two after the propofol was given, her oxygen saturation dove down to 60%, which responded to mask ventilation. When she came to a few minutes later, she began shivering and then increasingly agitated, diaphoretic, and combative. Vitals were done. She was tachypnic and tachycardic, and her temp was now 37.9 degrees Celsius, and she wasn't able to follow commands. So, Dr. Himmel, what do you think is going on in this case of a pretty run-of-the-mill procedural sedation gone bad?
Well, I haven't got a clue what's going on, but I do have a very good approach, which we should always follow. Keep an open mind. Do the ABCs. Airway, breathing, circulation, disability, do an examination, keep the people alive, manage their vital signs, and have a broad differential diagnosis. So how common is this event that you just described? Not very common. Did the person aspirate? Are they going through drug withdrawal? Have they had some organic catastrophe like intracranial hemorrhage? Do they have spousal abuse and they have injuries we didn't think about? Are they having internal bleeding we hadn't diagnosed at the time they fall? Did they fall because of drug interactions from excess alcohol use? You need to do an examination, have an open mind, listen to the chest, look for pneumonia, worry about sepsis. Get a cardiogram, O2 sat, IV, monitor. Is there any abnormality on the cardiogram? Well, when you've done all this stuff, recheck the patient, look at the vital signs. Then you're going to say, I can't find anything. What in the world's going on? I wonder if drugs are a problem. That's the approach that I would take. This person had a problem that came out of nowhere and most likely was a complication of the procedural sedation, and maybe she had pneumothorax, something we missed. And maybe she's got sepsis that she was developing before she fell. That's the reason she fell. But at this point, you've got to think about drugs. You got to wonder about sertraline, cetirizine, fentanyl, propofol. What could be going on? And they got a fever. And of course, the commonest causes would be sepsis or infection. But then you've got to think about serotonin syndrome.
All right. We kind of knew where this was going.
And of course, you're going to examine her reflexes and look for clonus. That's what you're going to follow in the back of your brain.
In particular, so this patient's on an SSRI and an antihistamine, and then was given fentanyl and propofol. So what do we need to know about those drugs in terms of serotonin syndrome?
Well, sertraline is a SSRI, so that's an issue. Well, 50 milligrams, they usually does not cause serotonin syndrome. It would be very, very unusual. Cetirizine is a second-generation antihistamine. That usually is not a problem. Fentanyl, it can contribute to serotonin syndrome, so you got to file that away, but the dose was not particularly large here. So as likely as it is, it's a possibility. She does have some issues here, and you've got to keep it in the back of your mind.
Yeah, you're describing here a patient with a relatively acute onset of what looks like a hyperkinetic state, altered mental status, and hyperthermia. And so the differential is extensive, as Walter went through. But in the context of drug interactions, serotonin syndrome would be the thing that comes first to mind. And opioids are often invoked as potential causes, and they can sometimes do this generally by interfering with the reuptake of serotonin from the synapse. I don't think it's all that common, though. I mean, I think it's sort of still the kind of thing that you'll give 100 patients on SSRIs, opiates, and not see a case of this, but it does happen from time to time. We see a lot of serotonin syndrome on our clin pharm service, and I won't say a lot, but we see it enough. It's sometimes tough because it's a spectrum, right? It's easy when the patient's got a temperature of 40 and they're seizing and they've got spontaneous clonus, but sometimes it's just as subtle as just checking the reflexes and they're just really brisk. I like to say if you need a reflex hammer, it's probably not serotonin syndrome. You tap on their patellar tendon and you'll be kicked by their foot. It can be subtle sometimes.
That echoes my experience 100%.
All right. So from a drug interactions perspective, SSRIs and fentanyl can cause serotonin syndrome. It's pretty rare, but we use a lot of fentanyl in the emergency department. And so I think it's something that you should just keep on your radar when you're giving fentanyl and someone's on an SSRI. I think it's still safe generally to give fentanyl in a patient who does take an SSRI, but if they do exhibit any signs of serotonin syndrome, then you know what you're dealing with immediately and you can address it. So this case is just one of many possibilities of drug interactions that I'd like to discuss. As mentioned at the top of the podcast, the most commonly implicated drugs are cardiovascular, antimicrobials, and analgesics. So let's start with antimicrobials. We've already touched on a few of these. Dr. Juurlink, you had mentioned the interaction between ACEs or ARBs and trimethoprim methoxazole, the brand names Bactrim and Septra. You had done a fantastic EM quick hit on this a few years ago, but I just want to kind of dig into it a little bit more and reiterate it here because it's a really important one. Why should we avoid giving Bactrim or Septra to patients who are taking ACE inhibitors or ARBs?
So before I answer your question, I just want to make a point about why antibiotics are just so important. It's because we just drop them into regimens all the time for like 7 or 10 days. And it's not that we don't think about it, but we are routinely stirring the pot with these drugs that we're prescribing with good intentions, but they've got a whole, especially the quinolones, macrolides, and Septra, have a whole host of potential interactions with other drugs, and so you really want to be mindful before you add it. So the issue with Septra, I know it goes by Bactrim elsewhere, but Septra is what we tend to say in Canada. So it's 2 drugs, right? Trimethoprim, sulfamethoxazole. The problem here relates to the trimethoprim. And I think it's really helpful if people just remember that trimethoprim isn't just an antibiotic, it's a potassium-sparing diuretic. If you give volunteers trimethoprim, they will lose salt and water in their urine and they will retain potassium. And the reason it does this is because it affects this channel in the distal nephrons called the epithelial sodium channel or ENaC channel. So when you give trimethoprim, the end result is that people lose sodium and water, they retain some potassium, and in somebody with normal kidney function or no other drugs on board, that's just not a problem, right? But if your creatinine clearance is 30 and you're on an ACE inhibitor or you're on spironolactone, those are the people who are at especially high risk of developing serious or even life-threatening hyperkalemia. Our group has actually studied this in a series of studies over the last decade or so. And so this is probably useful sort of framing, but if you've got a patient on an ACE or an ARB and you elect to prescribe them Septra, that person's relative risk of being hospitalized for hyperkalemia in the next couple of weeks is about 7-fold higher than if you'd given them, say, amoxicillin or nitrofurantoin, if that was clinically appropriate. It's an even greater risk if they're on spironolactones, around 12-fold higher. And we have one other paper that makes, I think, a pretty good case for sudden cardiac death in outpatients who are prescribed Septra and spironolactone in combination. It's rare, but it can happen, and I think that's generally happening because of hyperkalemia. And I think it's worth just also pointing out that it's going to depend a bit on the dose and the duration, right? So 3 days of single-dose Septra versus 14 days of Septra DS twice a day. I mean, those are going to convey differential risks, right? So the dose and the duration and the person's native kidney function and the other drugs they're on, these all play into the decision. This isn't to say that you should never prescribe Septra to a patient on these drugs, but it is a tangible risk. And the longer they're on it and the higher the doses, the greater the risk is.
Okay. And luckily, we have talked about this on EM Cases recently about the duration of antimicrobials in general, and guidelines keep on making the durations shorter and shorter and shorter. And so this is good for preventing hyperkalemia and death.
So I want to emphasize that. So those are the big three families. The trimethoprim sulfamethoxazole combination, family number 1, it's a big issue. Number 2, the fluoroquinolones. And number 3, the macrolides. So can I tell you a little story?
Absolutely, Walter.
So about 4 or 5 days ago, I saw a patient emerge who had a big swollen ear. And I thought they had either cellulitis of the pinna or perichondritis. I won't go into that differential story. It's a good story. But I was going to treat them for perichondritis, which, of course, can be due to strep, but is often associated with Pseudomonas. So for whatever reason, I gave them 2 drugs. I gave them Keflex plus Cipro. Well, 6 hours later, I was at home, and I got a phone call. And, of course, it was a pharmacist. And I have to admit, when I get a call from a pharmacist and I'm asleep, I'm not always charming. And they said, Cipro, this person's on Lipitor, atorvastatin, 80 milligrams a day. And Cipro and Lipitor may have interaction. This person was on 80 milligrams Lipitor a day. I had prescribed Cipro. As it turns out, that's a pharmacokinetic interaction. Cipro inhibits 3A4, the cytochrome. 3A4 metabolizes Lipitor. And by the way, Lipitor levels at error end of the graph can go up 200, 300, 400% in some cases. I had to stop the drug. Now, you've got to be specific. Simvastatin and lovastatin, the original one, Mevacor, is very much affected by 3A4. The other statins, less so. So fluoroquinolones are a big deal on pharmacokinetic reactions.
So Walter makes some good points, but there are the lipophilic statins here, and the easy way is ALS, Atorva, Lova, and Simva. These are statins that rely on CYP3A4 for metabolism. It's true that Cipro can inhibit CYP3A4. It's not a strong inhibitor. It's kind of at best moderate. Clarithromycin, which we don't use a lot of anymore, is just a profound inhibitor of CYP3A4. But it would be especially likely if the patient had, instead of being given Cipro, received clarithromycin or erythromycin, very strong inhibitors of CYP3A4, or if the statin had been simvastatin. So the concern you're worried about here is rhabdo as a manifestation of statin toxicity. That's the concern. And this is most likely to happen when it comes to drug interactions with Atorva, Lova, and simvastatin. ALS is the way I like to teach it. And it's especially likely with simvastatin because of all those 3 drugs, it's the one where turning off its metabolism by blocking CYP3A4 can cause a huge increase in its concentrations in blood, like 10 or even 16-fold. So the worry I would have here would be adding Cipro as kind of a moderate inhibitor. I'd be especially worried, though, about clarithromycin or erythromycin, which are very strong inhibitors of CYP3A4 and will predictably cause huge increases in the amount of simvastatin, lesser increases in Atorva. We don't see much lovastatin anymore, but those are the drugs that I'd worry most about here.
Okay, so macrolides plus I love that, ALS statins.
Yeah.
Those we need to really be worried about the possibility of rhabdomyolysis. So the other thing to think about with macrolides is their interaction with calcium channel blockers. So there's the macrolides and the statins that can cause rhabdo. Dr. Himmel, what about macrolides and calcium channel blockers?
Not that long ago, I had a patient came in with syncope, and the person was on a calcium channel blocker called amlodipine or Norvasc. Now, of course, there's lots of calcium channel blockers. Most are metabolized by the cytochrome system, but not to the equal extent. Unless you're a real expert, you wouldn't know, and not the same way in every patient. So this person was Norvasc, amlodipine. They came in with syncope, and their pressure was actually in the department about 70/20. And I figured, what in the world is going on? So the person got some fluid, and their pressure picked up a bit, but I was quite shocked. And here's the story. The person had hypertension. They'd been on amlodipine for years. They had developed a confident cold 4 or 5 days earlier and were prescribed Biaxin. First day they felt fine. Second day, they felt a bit off. The third day, they felt lightheaded. And the fourth day, they passed out in that syncope. So what in the world was going on? I did a syncope workup, the standard useless CT of the head, and all the other blood tests showed nothing, of course. I referred the person to medicine. And then I went to one of my little pocket calculators. I used something called PEPID, which I think is fantastic. And I put in the drugs, and it said amlodipine, Biaxin, drug interaction. When I found out by doing a bit of further reading that macrolides can inhibit the cytochrome system, especially 3A4, and amlodipine is a calcium channel blocker, which is heavily metabolized by the cytochrome system. And when you put someone on an inhibitor, it takes a day or two, but the CYP, the cytochrome, gets inhibited, and the Norvasc levels or amlodipine levels may have gone up 2, 3, 400%. So I referred the patient to medicine. Journal Journals was on, and I said, I think this is a drug interaction. And of course, I got the response that you always get. Nobody really believes you, and they were admitted to the diagnosis syncope NYD. I'm quite certain there was a drug interaction.
Lot of overlap here, thematically similar overlap with the statins. Same concept, same enzyme, same concept. And in fact, we studied this interaction about 10 years ago in CMAJ. And the key point to be made here is that, exactly as Walter said, macrolides will do this. We showed that there's I think up to a 6-fold increase in the risk of being hospitalized for hypotension in the week after getting one of these drugs, but it's specific to erythro and chlorithro. The nice thing about macrolides is today the one we mainly go to is azithromycin. And the great thing about azithromycin is that unlike its predecessors, it does not inhibit CYP3A4. So what that means is if you're an emerge doc and you want to use a macrolide, using azithromycin is much less likely to promote hypotension with a calcium channel blocker or to cause rhabdo with a statin. It just does not trigger the same processes in the body.
Fantastic. So if you are going to reach for a macrolide, reach for azithromycin. And remember that clarithromycin and erythromycin in combination with certain statins, the ALS statins and the calcium channel blockers, particularly amlodipine, can cause drug interactions, rhabdo, and hypotension, respectively.
Can I put one more small plug in on the azithro front? It's related because it's talking about the same antibiotics, but I know people get worried about QT prolongation with macrolides. There seems to be, for some reason, some special fear of azithromycin. We know that of all the available macrolides, azithro has the least effect on the QT than, say, erythro or chlorithro. It clearly can in some people, but it's not as bad as the other drugs that we used beforehand.
So the bottom line there is if someone comes in on clarithromycin or erythromycin with rhabdo or hypotension, think about these drug interactions. And if you're going to reach for a macrolide, azithromycin seems to be the safest one, at least in terms of drug interactions.
That's a great summary. And if they're a cardiac patient and they're on an antibiotic, now they get really sore muscles, you know what to think about.
Absolutely. If there were one or two other antimicrobial drug interactions that you think emergency physicians should know about, what would they be?
I try to talk a bit historically. You know, the good old days, we used to use sulfonylureas a lot and warfarin a lot. And they are actually both heavily metabolized by, as Dave said, cytochrome 2C9. So it was very commonplace back in the days when they used to use glycoside and diamicron and sulfonylureas, that if you put these patients on Bactrim, which inhibit 2C9, they could get prolonged hypoglycemia. It's less and less of a problem now. But when you've got patients who've been on sulfonylureas for a long time and they're placed on Bactrim, they can get profound hypoglycemia. I want to just warfarin a bit. Warfarin is slowly going away. It's unlikely to go away completely because of mechanical valves. But warfarin is metabolized by 2C9, sometimes by 2C19, and Bactrim is a pretty good inhibitor of that drug. So antibiotics and warfarin are a big deal. INRs often go up for many, many, many reasons, but with Bactrim particularly so. So when you have a patient on warfarin and you're going to give antibiotics, almost any antibiotic, you can leave them on the warfarin, but you should consider checking the INR at least every 2 or 3 days as an option and warning the patient to get it checked frequently. The other thing to remember is that when a patient is on an inhibitor of the cytochrome system and they stop the drug, it can take 3, 4, 5, 6, 7, 8 days for the inhibition to wear off. Don't be too quick to forget to get follow-up.
So we're going over the 3 common categories of drugs that are higher risk for drug interactions. And so far we've covered antimicrobials. Next up are the analgesics, and we've touched on some of these already. In both the cases we presented, opioids were actually involved, and we are still in an opioid pandemic, unfortunately. Dr. Juurlink, first, could you explain to us why opioids are high-risk medications for drug interactions in the first place? I mean, there's the obvious sedation, but besides the sedation, what else do we have to worry about with opioids and drug interactions?
The main concern with opioids and drug interactions relates to their effects on the central nervous system and the fact that we combine them so often with other sedating drugs, benzos, dimenhydrinate, Dramamine or Gravol, used all the time, quetiapine to help people sleep as well. So these drug combinations are good examples of ones that we should really try and avoid. It's easy to say, right? But we have very good evidence now that opioids and benzos together in combination convey an increased risk of death that is a function both of the dose of the opioid and the dose of the benzo. I would say that's probably the most consequential set of interactions with opioids out there. From an Emerge perspective, I think Emerge docs use celecoxib a fair bit, right? In medicine we do. Someone out there is prescribing Celebrex. We don't think of this very often as a trigger for drug interactions, but it can turn off a different cytochrome enzyme, CYP2D6, one we haven't talked about until now. That's the enzyme that turns codeine, an inactive drug, into morphine. It turns tramadol into its opioid metabolite. And so if you've got a patient on codeine or a patient on tramadol and you give them celecoxib, you can anticipate that they won't get any opioid. Or the flip side, in fact, the flip side may even be more likely. The patient comes to the ED, they're on 400 of celecoxib a day for some reason, and the doc gives them codeine or tramadol. Those drugs won't be converted to their active metabolites if celecoxib's on board. The enzyme that does that conversion is inhibited by celecoxib. This is an interaction that you might not necessarily trigger, but it might manifest as inadequate analgesia because the patient just can't activate the drug in the first place.
Interesting. The whole time you're talking about tramadol and codeine, all I'm thinking is, well, I never prescribe tramadol or codeine.
Excellent.
So I don't really have to worry about any of that.
I did sneak in there dimenhydrinate, Gravol or Dramamine.
Yes, good point, because in the emergency department, we use morphine and Gravol as a combination quite often.
Yeah, I think that dimenhydrinate is one of the most grossly overused drugs on the planet, and people don't know what it is. It's 2 drugs. It's a combination of diphenhydramine, Benadryl, and a little bit of theophylline. That's when you give somebody 50 milligrams of dimenhydrinate for their nausea, you're giving them a mix of Benadryl and theophylline. It works pretty well for motion sickness, but it does not work that well for the kinds of nausea and vomiting that we see. It's sedating, and it's got some drug interactions, but I think it's a drug that we go to much more readily than we should.
Yeah, I do recall multiple cases of patients in the emergency department receiving a combination of morphine and diphenhydramine. They're given discharge instructions. The discharge instructions are documented. The patient goes home, has no idea what the discharge instructions were, and had horrible outcomes because they didn't know to come back to the emergency department. Yeah. So we have talked in the past on EM cases about drugs that work and drugs that don't was one of our episodes. And we talk about antiemetics. In the States, droperidol, they're lucky to have that, which is probably the best antiemetic. And then we do have other options, metoclopramide. We've got ondansetron. It sounds like what we're agreeing on here is that dimenhydrinate, what is commonly known as Gravol in Canada, should rarely be used in the emergency department.
And the last point we can make from this is the following. Probably the biggest pharmacodynamic reaction for all Emerge doctors to know is additive drugs that give you sedation, sedation, sedation. Benzos plus opioids plus antiemetics. These people are going to be sedate And they're either going to have a good sleep or they're going to fall and break their hip or God knows what else. Be aware of sedation. I tell my residents, if you prescribe an opioid with a benzo to a patient, I will seek you out and punish you for the rest of your career.
So those are a few highlights when it comes to opioids. I want to talk about some other analgesics, NSAIDs, and we've touched on this with regards to Celebrex, and we've touched on this with regards to renal patients. But NSAIDs are used so often in the emergency department. I want to really kind of dig a bit deeper into NSAIDs. Dr. Himmel, what are the key morbid drug interactions we need to know about before we write up a prescription for, say, a pile of Voltaren?
Well, I have a love-hate relationship with NSAIDs. And most nephrologists I speak to hate NSAIDs. And most gastroenterologists I speak to hate NSAIDs. So it's a problem. If you're under 40 or 50 and healthy and on no medication and you need some analgesics, NSAIDs are probably pretty reasonably good. But here's the problem. There are interactions. Let me give the simple ones you always have to think about. If you're taking aspirin for coronary artery disease, you have an increased risk of gastric erosions even with a small dose. If you had an NSAID to a patient taking a small dose of aspirin, even 81 milligrams a day, you at least double the risk of gastric erosions, GI bleeding, and reflux. So somebody on aspirin, even a small dose, who is given an NSAID, is at risk of increasing GI side effects. Now, we do know that COX-2 inhibitors, like Celebrex and Mobicox and so forth, are supposed to be easier on your stomach, and I suppose they are except in large doses. But they all affect the kidney. So any NSAID will affect renal function. Now, of course, if you're on no drugs and healthy, not a problem. If you're on 3 or 4 or 5 drugs, such as a diuretic and an ACE inhibitor, or a diuretic and an ARB, or a diuretic and a drug like Entresto, and taking NSAID, you're going to get increased creatinine, water retention, sodium retention, hypertension. So people on multiple drugs and cardiovascular and NSAIDs are going to be very sensitive. People on aspirin who now are given NSAID are going to have trouble with GI bleeding and so forth. This is a big issue. And I see so many patients with hypertension now and emerge. I don't know what's happened, man. It's like they're going backwards 30 or 40 years. And if they're on NSAIDs for the last 3 or 4 days and their pressure is 220 over 110, you've got to consider it. Now, how about NSAIDs and coronary artery disease in patients with aspirin? I'd be very, very careful in patients with coronary artery disease on aspirin before I give them NSAID. I won't go into the details, but in addition to GI bleeding, in addition to reflux, in addition to acute kidney injury, in addition to hypertension, many NSAIDs have been reported to have increased risk of making your platelets more sticky. So I would be very careful with NSAIDs in patients. Most nephrologists I speak to and many cardiologists suggest if you have coronary artery disease, if you've recently had a stent, and you're on aspirin or clopidogrel, think twice before prescribing an NSAID. There's tons of potential issues over there.
There's 2 questions that always come up when it comes to NSAIDs. One is the duration of giving NSAIDs. And I've heard many emergency physicians say, look, if I'm giving ibuprofen for 3 days, it's not going to have any interactions with anything. I don't have to worry about it unless, someone's obviously on aspirin and a DOAC and has a history of GI bleeding or something, which shouldn't happen. But so there's the duration of NSAIDs. And then there's which NSAID. So I've heard that ibuprofen is probably safer than Voltaren or naproxen. The newer NSAIDs like Mobicox and Celebrex. Dr. Juurlink, with regards to which NSAID and the duration of NSAIDs, do we really need to worry about drug interactions if, say, we're giving ibuprofen for 3 or 4 days for someone with a sprained ankle?
We talked a moment ago about how celecoxib can inhibit cytochrome P450-2D6, CYP2D6, and interfere with the effectiveness of codeine or tramadol. It can even interfere with the metabolism of metoprolol, and you can find case reports of celecoxib-induced bradycardia in people who are on metoprolol. But one of the nice things about ibuprofen and naproxen in the short term is they don't do that. So if I have need for an NSAID for a couple of days, I would just personally go with ibuprofen and naproxen.
Okay, so we've gone on a little side trip here, but I think it's just so important to review there that if someone is on long-term Celebrex or Mobicox, we do need to look out for drug interactions, particularly with codeine, metoprolol. And if we're starting someone on an NSAID, probably the safest from a general adverse reaction and drug interactions point of view is ibuprofen or naproxen.
But remember, weird things do happen. And if you're going to prescribe an NSAID, and I think twice before doing it to a fragile person or a person on aspirin or a person over 70, you've got to tell them if you get heartburn, indigestion, abdominal discomfort, you better stop it. Because every experienced doctor has seen patients who take 1 or 2 NSAIDs and get a GI bleed. How common is GI bleed with NSAIDs? It's rare, maybe 1 case in 200 per year. It's not that common. But it happens. But certainly if they're on an aspirin or a clopidogrel and you're going to prescribe an NSAID because you feel you have no option, keep it brief. And if they have a drug plan, consider giving them a PPI concurrently and give them good instruction. Good advice is always important.
All right, so the last category of the 3 common ones that are implicated in drug reactions are cardiovascular drugs. And we've touched a little bit already on ACE inhibitors when it comes to hyperkalemia, and when we're talking about amlodipine and their drug interactions with macrolides. But I want to dig a little bit deeper into cardiovascular drugs. For this, let's just kind of take quick turns going back and forth in terms of cardiovascular drug interactions that ED docs need to know about.
Oh, there's so many, but if I had to pick one, I'll start with anticoagulants, so DOACs and warfarin. And so I think the main potential interactions there are going to be with antiplatelet drugs, so ASA or clopidogrel. And of course, it's sometimes needed that these drugs are combined together, but it's not uncommon to see someone on a DOAC and they've been on aspirin since the Clinton administration, and it's maybe time to come off the ASA. The reason that matters, the reason why the DOAC and antiplatelet matters is because when you knock off both phase 1 and phase 2 hemostasis, of course your risk of bleeding is going to go up. Acetaminophen is not a problem with DOACs, but it does have a potential and potentially serious interaction with warfarin that isn't widely recognized. And most docs have had anecdotes of people who come in with INRs of 9 or bleeds where it's clearly the acetaminophen, the new use of acetaminophen that has upended the effects of warfarin. And finally, I guess the other issue with DOACs is lots of drugs, a list too long to go into, drugs that when added to somebody on rivaroxaban or apixaban can mess with their metabolism or their renal elimination and predispose the patient to bleeding. So I would say that if you've got a patient on a DOAC or warfarin, before adding a new drug, it's worth just double checking to make sure that it's not one that's prone to interact with them.
Great. Yeah, because we start DOACs on lots of patients from the emergency department. And so checking their drug list to make sure there's not going to be any renal problems. And if they're on an antiplatelet, especially if it's for primary prevention, which we know isn't indicated anymore, we should be taking them off the antiplatelet before we start them on the DOAC. All right. And again, we're going to go back and forth here. Dr. Himmel, your top cardiovascular drug interaction for emergency doctors, what would it be?
Well, there's a drug called amiodarone. Amiodarone actually inhibits a lot of CYPs. It inhibits CYP3A4. It inhibits CYP2C9. So amiodarone is going to have interactions with statins and with direct oral anticoagulants. And I must say, they're usually not significant, but they can be. But here's the issue with amiodarone. Amiodarone does block the AV node. Beta blockers will affect the AV node and heart rates. Calcium antagonists will affect the AV node and heart rates. So when you've got somebody on a calcium antagonist like verapamil or diltiazem and or a beta blocker and or amiodarone, and they've got a very, very slow heart rate or secondary heart block, you could be looking at a pharmacodynamic relationship. Now, this is commoner than you might think. Now, talking about slow heart rates, I want to talk about another drug that's used for patients with cognitive impairment and dementia. And there are drugs like Aricept or Rivastigmine. I guess they're the cholinesterase inhibitors. Now, this is big. This is really, really big. I recall seeing patients on dementia drugs, cholinesterase inhibitors, who occasionally get heart rates of 35 or 40 because cholinesterase inhibitors for dementia will release acetylcholine. One of the cardiologists I spoke to years ago said, yeah, occasionally we put pacemakers in people so they take their dementia drugs. So keep in mind that dementia drugs can be associated with bradycardia, not commonly seen. But once you add a dementia drug and a beta blocker and a calcium antagonist and amiodarone, you can certainly get significant bradycardia. That's a big deal. The other amazing thing is eye drops. I've actually seen this, and I didn't believe it when I saw it. There's a group of eye drops which are beta blockers called, for example, timolol, used for glaucoma. Timolol, used in eye drops, is extremely well absorbed, and as unbelievable as it may sound, if you're on a beta blocker or a calcium antagonist and your resting heart rate's 55 or 60, and you now take a beta blocker like timolol, the interaction is pharmacodynamic. A beta blocker, the eye drop, and a beta blocker orally, or a calcium antagonist orally, you can get significant bradycardias.
All right, that's fantastic. So I think we're all pretty aware that all the different blockers shouldn't be combined, but that one with the dementia medications like Aricept, for example,
Bradycardia, sure.
That's a big one that I think most of us don't know about. Excellent.
We did a paper some years ago, not an interaction study, but it was just looked at the relative risk of being hospitalized for bradycardia after starting these drugs. And it was around threefold short-term increase in risk. What was neat was a sizable proportion of the patients who came to hospital with bradycardia after having initiated a cholinesterase inhibitor had a pacemaker inserted. And I mean, it might be the case that people just aren't recognizing the fact that bradycardia is expected when you block the ability to break down acetylcholine. Don't be surprised if the heart rate drops.
So far with the cardiovascular drugs, we have talked about DOACs and their interactions with the long list of drugs that alter metabolism or elimination. And we've talked about dementia drugs combined with any of the blockers and bradycardia. Dr. Juurlink, your turn. Another cardiovascular drug, big one that we should know about?
Insulin and beta blockers. This is something that isn't widely appreciated. And what's neat about this interaction is they don't really influence each other. Like insulin doesn't change metoprolol levels or vice versa. But if you start a patient on one of these, you might get a call from the pharmacist. And the concern is that in patients who are prone to hypoglycemia, the use of a beta blocker can mask some of the sympathomimetic features of hypoglycemia. So in other words, it can make the patient less aware of the fact that their sugar's low. One more that I think flies under the radar all the time, and this isn't typically life-threatening, although it could be, it's the combination of PPIs and diuretics. And the problem here is hypomagnesemia. So this is important because everybody's on a PPI. And diuretics, we throw them around all the time. And when I have a patient on my medicine ward whose magnesium is low, I just reflexively look at their med list, and I would say 30 or 40% of the time they're on both a PPI and a loop or thiazide or both. And what's happening here, why do they have hypomagnesemia? It's a two-hit problem. The first hit, obviously, is the diuretics causing the kidneys to waste mag. But the PPI plays a role in that the absorption of magnesium from the gut involves an active transporter, and PPIs turn that transporter off. So PPIs on their own don't tend to cause hypomagnesemia because your kidney just reclaims it. But if you both can't absorb magnesium and have trouble reclaiming it from the tubules, you're at risk for trouble here. So this is a nice, easy one. And, rarely is it clinically dangerous. You can see it. You can imagine a scenario where someone's mag is 0.2 and their QT is long and they come in with syncope. But it's a nice, easily correctable drug interaction that I think we don't pay enough attention to.
Amazing. So with our cardiovascular drugs, we've talked about dementia medications that interact with blockers causing bradycardia. DOACs plus antiplatelet drugs or acetaminophen or drugs that alter metabolism or elimination, the ones that affect the kidneys especially. So DOACs plus those. We've talked about insulin and beta blockers. And we've talked about PPIs interfering with diuretics. I had no idea about that one and causing hypomag. I know I've learned a whole pile of things about drug interactions from Dr. Juurlink and Dr. Himmel here. This was a real eye-opener. if there were one or two or three key take-home points that you'd want our listeners to know about drug interactions, what would they be? Dr. Juurlink?
Well, I think one take-home point that's probably pretty obvious to all is that this is a vast topic, and no clinician, as much as they might try, can keep drug interactions straight. There's just thousands of potential interactions out there. So the question is, how do you avoid hurting people with a drug interaction? And I think some common sense rules help here. One is be careful when you're adding a new drug, but be especially careful when the patient is already on a drug that you don't want to mess with, a DOAC, an anticonvulsant, immunosuppressant, and so on. But I think the other really useful point that we haven't talked about is make sure the patient goes to the same pharmacy all the time, because it's when they go to the pharmacy and they bring the new medication to the pharmacist and it's entered in the computer that the computer software, which is imperfect, but it's better than the human brain, will flag the potential drug interaction. It's just part of the whole Swiss cheese model of preventing harm.
Great practical point. And Dr. Himmel?
Yeah, I think you've always considered the patient. Who is the patient at risk? Multiple drugs, fragile patients, physiologically challenged. These are the ones at risk. I've learned basically if nothing makes sense, look at the drugs. If nothing makes sense, look at the drugs. And for better or for worse, you've got to realize a lot of potential drug interactions don't matter, some really matter, and it's tough to know the difference. And certainly the three antibiotic classes we emphasized, sulfa, fluoroquinolones, macrolides, are a big deal. The cardiac drugs like beta blockers and calcium antagonists, blood thinners are a big deal. And renal function. The worse the renal function, the bigger the risks. Always give the patient a lot of advice before they go in and give them new drugs. Discuss, they get new symptoms, new side effects, indigestion, this you're lightheaded, you got to be reassessed.
I love those 2 points. One is to keep to the same pharmacy, very great practical point. And the other one is the discharge instructions. There's always a potential for drug interaction that might surprise us and the patient. And so good discharge instructions when you're adding any new medication to look out for side effects is an excellent practical point as well. So thank you so much, gentlemen, for your insights into the massive world of drug interactions. I hope we highlighted a few key things that will stick in our EM providers' brains and hopefully save a life in the emergency department.
Nice.
Well done, man.
Good.
That
was fun.